start the talk.
First of all, I will like to thank the organizers of Diabetes India for inviting me and giving me this very important topic, that is understanding pathophysiology of glucagon in diabetes. And I will like to thank especially Dr. Bansi Sabu for giving me this opportunity to talk about the topic, which is very, very important and pertinent. I will be talking about glucagon. So first, in early 1920s, the Kimball and John Merlin identified pancreatic extracts, and he found that it is responsible for blood sugar increase rather than increase, and later on it was termed as glucagon. Glucagon is a 29 amino acid peptide hormone, and it is a counter to insulin and stimulated hepatic glucose production, and also it increases plasma glucose level by both mechanisms, that is glycogenolysis and neoglucogenesis. Glucagon also stimulates ketogenesis, thus working in tandem with insulin to maintain a normal fuel balance. That is why probably nowadays we are talking more about glucagon because of this particular action. Insulin, we know, acts as a glucose depositing and anabolic hormone, and counter to that, glucagon is a glucose mobilizing and catabolic hormone if you compare with the insulin. Most important thing is that we know that beta cells are responsible for secretion of insulin and amylin, while the alpha cells are responsible for secretion of glucagon. We also know that at the time of birth, the beta cells are more in number, around 60% of this total cell of islet of Langerhans are beta cell, and the rest are, most of them are alpha cell, and very few belong to other varieties. So this insulin glucagon ratio becomes very important because we know that both alpha and beta cells are formed by same precursor. That is why today's concept is that probably alpha and beta cell have same progenitor cell, so the alpha cell and beta cell are interconvertible. Insulin glucagon molar ratio is more important rather than the beta and alpha cell ratio, because it is the ratio in plasma, it is more important than their individual constitution. So it may not be that important that how much insulin one is having and how much glucagon is having. Probably it is the ratio of insulin and glucagon is more important. Normally the IG ratio, which is called as insulin glucagon ratio, following a balanced diet is approximately 3, meaning by that 3 is insulin and 1 is the glucagon. So following overnight fasting, it decreases to 1. So in normal person without any disease, the IG ratio keeps on changing. It varies from 3 to 1. So after diet, it is maximum 3, and in fasting condition, it is 1. When person goes to prolonged fasting, more than 24 hours, or even more than that, the ratio may be as low as 0.4, because in that condition, hardly any insulin is secreted, only basal secretion of insulin is there, and glucagon keeps on increasing. Following glucose infusion, the ratio may rise up to 30. When glucose is given, then that stimulates insulin secretion, and this IG ratio goes up to 30. In diabetes, inappropriate IG ratio influences metabolic status. So in other terms, in diabetes, we should also focus the IG ratio, which is a very important factor. What is happening by glucagon? Glucagon secreted by the pro-glucagon molecule as a pro-hormone like the insulin, and it is converted into glucagon by pro-hormone convertase 2. And this pro-hormone convertase 2 is rarely deficient, so it is easily converting the glucagon into pro-glucagon into glucagon. By portal circulation, like the insulin, glucagon reaches to the liver first, and first receiving organ is the liver, similar to insulin. And this in liver, it produces glycogenolysis, gluconeogenesis, fatty acid oxidation, and ketogenesis. These are the four important functions glucagon produces in the liver. And their order is also same. That is, first action is glycogenolysis. And we know that the liver glycogen, whichever store is there, is depleted within 12 to 15 hours. And now no glycogen is left in the liver. We also know that the muscle glycogen is only for that particular muscle, while the liver glycogen is for whole of the body. And this glycogenolysis produces more glucose, that is hepatic output of glucose. When glycogen stores are depleted, then gluconeogenesis starts and fatty acid oxidation and ketogenesis follows. Epinephrine and other counter-regulatory hormones provide gluconeogenic precursors like lactate, amino acids, glycerol to liver for raising blood sugar. So they do have their function, but they will provide the gluconeogenic precursors like lactate, amino acid, glycerol, etc. But the main function is done by glucagon. So factors which regulate glucagon secretion are so many, and the secretion of glucagon is increased by hypoglycemia, and the carbohydrate and meal stress decreases the glucagon secretion. Protein meal increases glucagon secretion, while isoleucine decreases glucagon secretion. Most of the amino acids increase glucagon secretion, while non-esterified fatty acids decrease the glucagon secretion. Some fatty acids may also increase it, but ketones definitely decrease glucagon secretion. Parasympathetic nerves, when the parasympathetic stimulation is there, the glucagon secretion will be more, while the gamma-aminobutyric acid, GABA decreases glucagon secretion. Sympathetic nerves also increase glucagon secretion, while the ATPs decrease glucagon secretion. Whenever there are more ATPs already present, then the glucagon will be decreased. The pituitary adrenal cycloactivating polypeptide, this increases glucagon secretion, but the zinc decreases glucagon secretion. Cold exposure have been seen to increase glucagon secretion. So glucagon will be more in temperate countries in relation to tropical countries. Hormones which have the impact on glucagon secretion, the adrenaline or epinephrine increases glucagon secretion, and cholecystokinin increases glucagon secretion. Gastrin-releasing peptide, ghrelin, GIP, oxytocin, vasoactive intestinal peptide, and vasopressin, they all increase glucagon secretion. And amylin, glucagon-like peptide, GLP-1, insulin, leptin, secretin, and somatostatin, they all decrease glucagon secretion. So this was the hormonal actions, various hormones which have action on the glucagon secretion. What is the mechanism of action of glucagon? Glucagon acts by the glucagon receptor, and you see the glucagon receptor serpentile structure, and this receptor, when the glucagon combines with this receptor, a lot of activities take place. And this is regulated by inositol and triphosphate INSP3 pathway, and that increases calcium ions, and that again is responsible for glycolysis, glycogenesis, gluconeogenesis, and increasing glucose. This is also potentiated by lot of activities, and again it is by adenyl cyclase CMP pathway, and inside cytoplasm it increases the pKa, and that increases PGC1 and the G6 phase, and is responsible for most of the action of glucagon, which are glycogenolysis, and the gluconeogenesis. The glycolysis and glycogenesis is decreased, while the glycogenolysis and gluconeogenesis increases. So that is responsible for hepatic output of glucose. This is the pancreatic islet structure, which facilitate pancreatic signaling, because this structure is unique. You see, exocrine pancreatic glands are outside and they are acinar cells and they secrete pancreatic juice and they have no role in the endocrine role and they are exocrine process. But we know that endo-exo connection do exist and endocrine functions are affected by exocrine functions and vice versa. The alpha cells, you say they are lined, related close to exocrine pancreas, and you see beta cells are little inner inside, delta cells are also inside, and you see that F cells are also there. So what happened that the various hormones, which are secreted by the same cell, they do have the action on the same cell, and we know this is called an autocrine effect. And when the beta cell secretes something and which is having action on alpha cell, this is called as paracrine effect. So both paracrine and autocrine effects are responsible, meaning by that the release of glucagon has action on the alpha cell and vice versa. Similarly, the beta cell release, that is the release of the insulin and amylin, will have impact on the release of glucagon, and vice versa. That is, glucagon release will have impact on the amylin and insulin secretion. So we know that these paracrine, autocrine, neurocrine, endocrine, exocrine effects are responsible for most of the action which we see in a tandem manner. Centrifugal pattern of blood flow in pancreatic islet to facilitate paracrine regulation of blood glucose. This is possible by centrifugal pattern. Blood enters from center and drains outwards. So this blood flow pattern allows secreted hormones to regulate other cells within the islet. This is possible by centrifugal pattern. You see here the regulation of blood glucose by insulin and glucagon in a healthy individual is possible. That is in hyperglycemic condition. Pancreatic cells, beta cell release insulin, and these insulin stimulate glucose uptake by cells, and they also produce glycogen synthesis in liver, and in the liver and the other cells, including the fat cells, the plasma glucose return to normal levels because the muscles now can utilize glucose. The adipose tissue can synthesize more fat, and the glucose can synthesize more glycogen in presence of insulin. So blood glucose returns to normal. And then what happens in the fasting condition or when the person is developing hypoglycemia, then alpha cell secretes glucagon, and this glucagon produces glycogenolysis, and it also inhibits the glucolysis, and the neoglucogenesis do occur, and that maintains plasma blood glucose to normal level, and this is the action of the glucagon. Alpha cell glucagon secretion dependent on beta cell insulin secretion that I have already talked about, and pathophysiology type 1 and advanced type 2 diabetes happens that when there is no insulin, so glucagon increases, and when even insulin is there, then the glucagon increases. This is the special thing, and even after the fasting condition, glucagon secretion should go out, but even in prandial condition, glucagon continues to increase, and glucagon increase is one pathophysiology which is central in pathophysiologies of type 2 diabetes. We know that in type 2 diabetes, the more and more pathophysiologies are known, but this one pathophysiology which is part and parcel of the ominous octet that has shown that increased glucagon level is a very important pathophysiology. The aberrant secretion of glucagon resulting in elevated glucagon concentration in both the fasting state and after meal are important. In altered alpha to beta cell ratio may be a contributing factor in type 2 diabetes pathogenesis. The relative hyperglucogonemia of diabetes resulting from an altered alpha to beta cell ratio might be a consequence of beta cell T-differentiation to glucagon producing islet cell, which I talked earlier that both cells are from same progenitor cell, and due to that more alpha cells are being formed, and that is evident that after 10 years of type 2 diabetes, the alpha cell increase in the number and the beta cell goes down, and the condition reverse. Now 60% of the islet of Langerhans are alpha cell and only 40% beta cell. Glucagon also plays a role in lipid metabolism, influencing food intake, affects body weight, promotes autophagy, and has pleiotropic effect on the cardiovascular system. We know because of these pleiotropic effects, the glucagon is being discussed during these days, and we know that it has impact on lipid metabolism, food intake, and body weight. The high insulin, when we talk about insulin-glucagon interaction, the high insulin-glucagon ratio promotes biosynthesis of proteins, inhibits glucose production, and reduces release of free fatty acids. So, a low insulin-glucagon ratio helps the body access stored nutrients, increase hepatic glucose production from glycogen and amino acids, and promotes the breakdown of adipose tissue into free fatty acid and glycerol. It is called as the physiological fulcrum. This insulin-glucagon interaction is called as a physiological fulcrum, balancing the two opposite ends of the metabolic spectrum to conserve energy if possible, but provide it when needed. So both are required. Sometimes we need that energy should be conserved, and sometimes we need that energy should be provided. So that is possible only by flipping off the switch and making the insulin-glucagon interaction in a different ways. Now I will talk about effect of various drugs on the glucagon levels. You see, we are using a lot of OHAs in the type 2 diabetes management, and metformin also acts by inhibition of glucagon, induced stimulation of gluconeogenesis. So one of the action of metformin is by inhibiting glucagon, which we are achieving by GLP-1. So the combination of GLP-1 RA drugs with metformin can be a synergistic combination because both will have synergism. Metformin also acts to antagonize glucagon by affecting the cyclic exogenous insulin and was shown to decrease plasma glucagon levels in the patient with type 2 diabetes. So it was seen that metformin has two actions which are in favor with the management of type 2 diabetes involving glucagon. Exogenous insulin was shown to decrease plasma glucagon levels in patients with type 2 diabetes. So that is why the exogenous insulin is somehow helpful in decreasing the plasma glucagon levels. Sulfonylurea and pioglitazone have not been shown having any potential effect on glucagon levels. Experimentally, few studies have shown, but finally, we have not found enough studies which can claim that glucagon levels are affected by sulfonylurea and pioglitazone. Amylin mimetic decreased postprandial glucagon levels. We don't have these drugs in my country, but those drugs which countries are having this drug did decrease postprandial glucagon levels, similar having the paracrine effect. The GLP-1RA DB4 inhibitors decrease postprandial glucagon levels, thus increase insulin glucagon ratio, and that is why they are helpful and in the management of type 2 diabetes. SGLT2 inhibitors produce increased fasting glucagon and postprandial glucagon levels and decrease insulin glucagon ratio. That is one thing which is being discussed with SGLT2 inhibitors, and that is why when we combine SGLT2 inhibitors with DB4 inhibitors, then we say that probably this action is negated by DB4 inhibitors. Glucagon in hypoglycemia and hyperglycemia in diabetes. Type 1 and advanced type 2 diabetes mellitus, there is beta cell failure, and that is responsible for absolute endogenous insulin deficiency. And when there is absolute endogenous insulin deficiency, abnormal glucagon secretion is involved in pathogenesis of both hypoglycemia and hyperglycemia in diabetes. So glucagon behaves differently when insulin is available and when it is not available. Relevance of glucagon to hyperglycemia in diabetes finally leading to DKA. Insulin deficiency, infections like pneumonia, UTI, cellulitis, inflammations like pancreatitis, cholecystitis, intoxications like alcohol, cocaine, infarctions, acute MI, CVA, iatrogenic corticosteroid surgery. These 6 I are responsible to produce these conditions, and where the demand of insulin increases, and here the glucagon becomes very important and in the prevalence of the DKA. The role of insulin and counter-regulatory hormone like glucagon in pathogenesis of DKA. When insulin is decreased, free fatty acids rise, acetyl coenzyme may rise, ketone bodies rise, and these ketone bodies we know glucose is also increased. They produce hyperkalemia, hyperosmolar condition, and acidosis, and the ketone bodies are responsible for at least two symptoms. They are vomiting and kusumal breathing, which is pathognomy of DKA. Another story coming there is increased stress levels, and when the simple nervous system is not responding to that, and catecholamine levels and glucagon rise, and the glycogenolysis occurs, gluconeogenesis from amino acid, lactic acid, glycerol, and increased glucose levels are seen, and the osmotic diuresis is there, and that is producing dehydration. So all the three, dehydration, ketone bodies rise, hyperkalemia, hyperosmolar condition, acidosis are explained by this interaction of glucagon insulin. So when glucose level goes down, the pancreatic islets, beta cell failure, there is decreased insulin, and alpha cell secrete more glucagon, and the glucagon is more, and it prevents hypoglycemia. So in conclusion, we can say that glucagon dysregulation contributes substantially to the pathophysiology of diabetes, and utilizing hypoglycemic therapies which target glucagon can help improve glycemic control. Certain agents currently used to treat diabetes may exert some of their hypoglycemic effects by restraining glucagon secretion or inhibiting glucagon action. For example, mechanism of metformin may involve inhibiting glucagon signaling in hepatocytes, whereas GLP-1 receptor agonists and DPP-4 inhibitors have been shown to reduce glucagon excursions in patients with diabetes. Optimizing diabetes therapy in the future will require skill targeting of alpha cell dysfunction, balanced with insulin replacement therapy. So that will be the crux of knowing glucagon better. Thank you. Thank you very much. These were my references. Thank you. Thank you. Thank you very much.